All right, for the sake of time, we'll probably get rolling here. So, hi everyone, welcome. On behalf of the CDMS, really wanted to thank Alan Fang and Peter Zigilowski, who are gonna. Sorry, Alan Fang for organizing this with Matt Spector and Peter Zigilowski as the discussants. We have three cases of three separate universities and separate mentors. Victoria Yu presenting under the supervision of PY from the University of Michigan. Noémie Villemort-Palequin is going to be presenting on behalf of Dr. Joel Davies from the University of Toronto at Sinai Health. And we have a fellow from Dalhousie who couldn't make it but did all the work, and Ayham Al Afif is his supervisor at the University of Dalhousie. So I'll hand it off to Alan, and I hope you guys enjoy the Osseous reconstruction session.
Awesome. Thanks, Tony. Appreciate it. And thanks everyone for coming. And thanks to obviously all the fellows, all the discussants, AHAM, Dr. Alfif, Joel Davies, and PY, Dr. Lamanchi. And very lucky to also have a couple expert discussants, Matt Spector at the University of Pittsburgh and Dr. DZ, Peter at Florida. So we're going to be talking about challenges in osseous reconstruction in the head and neck. And so we got three really good cases for you. We'll try and keep them to, 10
What's
to...
up? How's life?
Hey, what's up, Jason? That was a nice view of you, by the way. We'll try and keep the presentations to around maybe like 10 to 15 minutes. I'll try and be ruthless and cut you guys off if you're running over, just so we can have a little bit of discussion, because I think that's where the real pearls are. So we'll start off with a case from University of Michigan.
Hi, everyone. My name is Victoria. I'm one of the fellows at University of Michigan. Thanks for inviting us to present this month. So I'm going to be presenting a case. My preceptor for this is Dr. Yalamanchi, and a special shout out to Dr. Casper, who was also one of the faculty on this case. So in lieu of a word title for this presentation, I put a screenshot of our virtual planning of the resection, and so that you all could ponder what you would perhaps do to reconstruct this defect. And in the meantime, I will give you some background on this patient. In the discussion of this case, we'll be talking about principles of mandibular reconstruction with a highlight on temporal mandibular joint management and trismus management. We'll also touch briefly on mandibular rescue for osteoradionecrosis. So the patient is a 75-year-old lady. She has recurrent mandibular squamous cell carcinoma and extensive osteoradionecrosis from what she originally had, which was a PT4AN0 right mandibular squamous cell carcinoma. She underwent a number of surgeries and treatments for this, which I'll detail in the following slides. She had a couple of other cancers as well, was a former smoker. Those are the relevant historical points. So to start, she was originally a patient of the oral surgery team. She had presented with an alveolar ridge lesion, and underwent a composite marginal mandibulectomy. Specifically, the team had left a 1 centimeter inferior border on the mandible and then had placed a 3 millimeter reconstruction plate with a radial forearm for soft tissue coverage. Um, she underwent adjuvant radiation, and about a year later, unfortunately, developed osteoradionecrosis as well as fistula formation that was recalcitrant, and so ultimately had to undergo removal of that plate with some local tissue rearrangement. Ultimately, she wound up transferring her care to us in the otolaryngology department. This is a clinical picture of what things look like around the time that she came to us. And then here is also a quick scroll through of what things looked like after. Sorry, I'm going to slow this down a little bit because, yeah. So there's that. All right, so we have a patient who has this refractory osteoradial necrosis, right? Refractory to conservative management, to kind of an attempt of debridement and local tissue rearrangement. Now has extensive osteoradial necrosis, full thickness with a pathologic fracture, and is coming to us with oral incompetence and drooling and trismus. So what can we do for her? We'll take a brief interlude here to talk about one option for patients with recalcitrant osteoarterial necrosis, which is this concept of mandibular rescue. This is a concept that was kind of formally described and popularized by Dr. Fritz and his group at the Cleveland Clinic. The idea is that we're using vascularized tissue to try and stop the progression of osteoarterial necrosis. And the way that he described it, it's kind of evolved over the past half decade or so. But originally, it was described as an anterolateral fascial lata flap. So essentially, harvesting of a perforator-based ALT and then removing the epidermis, dermis, and subcutaneous tissue and just leaving the fascia to drape over the remaining bone, and then using the skin to skin graft whatever's needed. There's a picture of that here on the left. But over the years, the group has also described modifications to this to involve some help with the bony reconstruction of these defects. And so initially iliac crest bone grafts for mandibular height, and then also later for full thickness defects or disease. Using a spanning reconstruction plate. And then also a note of trying to use superficial temporal artery as opposed to facial vessels to try and decrease the risk of fistulization. But that is not what we did for our patient, as she had pretty extensive, as you saw, kind of soft tissue defect, and also at that point, like very wide or extensive osteoarterial necrosis. So our plan was actually to do a multi-stage reconstruction, first with soft tissue, and then later to reconstruct the bony part of things. And so she underwent a first phase of this with an ALT, and this is what she looked like afterwards. Unfortunately, before we could get to the bony stage of things, she was found to have a recurrence on the contralateral side. And so that, of course, altered our plan for her, our surgical plan, and increased or made more sizable our defect. And so we were faced with this defect to reconstruct. And so here we'll just go through a couple of principles. It's late in the year, so I won't belabor the first couple points. But as with any type of defect, we're looking to classify it, maybe not with a specific classification system, but just to think through what is it that needs to come out, what are the functional implications, and then what do we need to do to reconstruct to help rehabilitate those functional deficits. And so for mandible specifically, these are just two classification systems that have, I guess, are historic and I suppose present relevance as well. Dr. Erkins and Dr. Jewers. But essentially what they're looking at is how much bone are you taking? How much soft tissue are you taking? And for mandible specifically, whether this is more posterior or more anterior, because those have different implications for function. Generally for anterior defects.
Victoria,
Oh,
sorry to cut you off. I'm being cognizant of time because this looks
yeah.
like an awesome case.
Sorry. Okay, I'll keep going. Yeah.
Just speed up a little bit. I didn't know how
Yeah.
to
Okay.
do it without cutting you off.
Sorry. Yeah. Thanks. Appreciate it. Okay. Yeah. So these are
Now
straightforward.
you know how my fellow feels.
Yeah. So straightforward things, right? There are a lot of options for reconstructing. So we'll just talk about, when and why should you do bone reconstruction? This is a nice graphic from the plastic group at MD Anderson, Dr. Hanasono's group. But basically, the kind of two important factors to consider, anterior versus anterior or crossing midline versus posterior, and also the patient's functional status. So again, if you have an older, sickly patient, edentulous, posterior defect, then could consider soft tissue reconstruction or letting them swing. If it's going to be a younger patient who wants dental rehabilitation, is an anterior defect, then you're going to think more about doing bony reconstruction. Here, we also wondered, right, because our defect spanned the joint, how do you reconstruct that? What are considerations for trismus? TMJ, key player for mastication, stable occlusion, and facial symmetry. There are a couple different ways to reconstruct it. You can use alloplastic or autologous materials. Alloplastic, I think the stock implants have fallen out of favor, but there are certainly custom ones, and with the advent of virtual surgical planning, customized ones, but also using autologous materials. So just sticking an arm of that fibula into the joint, or using um, if the condyle is itself free of disease, using a non-vascularized condyle graft from the patient as your implant or your prosthesis. And the other consideration here is coronoid management. So thinking about whether choroidectomy would benefit the patient from a trismus standpoint. Um, Great.
The anticipation is killing me. What did you guys do?
So we did here we go. This is what we did.
Yes.
So we did a four segment fibula essentially, um, with a um, with a temporomandibular joint prosthesis that was custom printed via virtual surgical planning. Here's what it looked like down on the leg, and here's what it looked like in the patient. Um, and here's what it looked like when we looked at it on CT. There it is. Nice, the key. And then just an afterthought for him, which is, a lot of bone stock that was used. And so, of course, shortened your pedicle. And so, an interesting paper or series recently published describing this FHL-based fibular segment for ramus reconstruction. The idea being that you take the proximal most segment, you strip the pedicle off of it, but you keep the FHL shag carpet on it, and the bone is perfused by the muscle and its by way of its perforators. Um, so interesting thought there, something we could have considered for Our Lady potentially. And then here, just post-operative points. She was weight bearing on day one, was discharged post-op day 16, and then was started on PO on her first post-op visit. These were pictures of her from post-op day 44. She did unfortunately recur and passed, but in the time that she was alive after the surgery, did have good PO intake, improved trismus from even this picture that I showed here. There were some after that. And a very nice point that Dr. Yalamanchu was able to relay is that she had been wearing a mask to cover that facial defect or skin defect that she had for a very long time. And after the surgery, stopped wearing a mask. So that was nice. And that is all I've got for that.
That's great. Thank you, Victoria. It's really interesting, obviously super complex case. I guess before Matt, what do you brought up the fact that this is Victoria, that you guys thought it was ORN for a while, and then you kind of found this
Mhm.
squame in there. Matt, how do you think about these kind of complex radiated patients with like these new or enlarging ulcers breaking down? Do you think cancer first always versus ORN, and then just anything else you want to talk about for the case specifically?
Yeah, thanks, Alan. I stage ORN reconstruction a lot of times, kind of like you just pointed out, right? So rescue flaps can be great, but you got to make sure that that bed is clean and you're doing a bunch of biopsies to make sure there's not cancer there, right? It sounds like this patient had a recurrence and ORN and then a second recurrence right there. So maybe the other, it could have been cancer in this whole mandible the entire time. This is a tough case. I don't know that I would have staged it. I got to think. So the benefit of staging is to create a safe wound, but there was a big fibula skin paddle there. Like if you saw the size of the fibula skin paddle, so there was intraoral and extraoral reconstruction, which is hard to stage, right? Like if you're trying to get these sealed from, usually you'd seal the inside first and not the outside. But I could see where if you're going ORN versus cancer, it can be hard to sort out. So, I mean, the picture there is a pretty good result. It'd be interesting to see. Can you play the CT scan again of the axial?
Yes. Post-reconstruction, let's see.
I mean, this patient is almost it's almost unreconstructable as you play this, right? Like this is I mean, both of her lips, she's got no sensation on either lip, right? Her tongue has a big skin paddle in there, and then the whole mandible, right? I mean, oh yeah, you had it there, right?
Did you post-reconstruction or
Yeah,
pre?
reconstruction,
Sorry, pre or post?
post reconstruction.
Post. Oh, okay, so I did have it. Sorry.
Yeah, and that's what I was gonna bring up. I mean, question for you, PY. When you're thinking about this, and I saw you put like a TMJ, like a little condylar implant up there. How are you kind of thinking about bony reconstruction versus maybe not, right? Because sometimes I think about we all want to give the Rolls Royce, but like I'm happy with a Toyota Corolla. It's my first car, 91 Toyota Corolla with a LeBron in it, by the way. Great
And real
car.
quick, before you answer that, PY, did you see where the prosthetic was? The prosthetic is forward here, right? It's hard to get these prosthetics to stay in place, especially when you have destabilization of the mandible, right? Your prosthetic is there and the glenoid's behind there, so it's down and back. So not that the patient couldn't have a reproducible bite with this, like it probably, like she had good competence on your picture, but it's really hard. See, the prosthetic is actually lower and to the side from the glenoid, so the whole thing kind of stuck down. So that's another hard thing about putting a prosthetic up there with a whole mandible reconstruction is to getting everything to stay up like you want it.
Yeah, absolutely. Yeah, I inherited the patient after the ALT reconstruction, and she really was interested in, she had been kind of waiting a very long time for having her mandible reconstructed. And exactly like you mentioned, Matt, she was in a tough spot because both of her inferior alveolar nerves are gone, both of her marge are gone. And so she had no sensation with drooling and trismus. And then in terms of the joint, the TMJ prosthesis, I definitely think I got sold this prosthesis a little bit when in my VSP planning process, to be
You have to put some
completely
disclosures on your slides now, or what?
to be completely honest. I think one thing that we've done since then is going with the allograft option and just taking the patient's native tissue and just adding that on as like a graft to your fibular reconstruction, and that it can be quite nice. And then you don't have to worry about the age of the prosthesis. And it obviously she ended up recurring and having distant disease, and her course was different, but these last for about 10 years. So, and I just used a suture to secure it with PDS into the glenoid fossa. So placement wise, it was a relative significant improvement for her, but
No, he's just sad.
certainly not a perfect placement.
Yeah. And DZ, any particular thoughts you wanted to talk about for the case? And I guess one other general question, I guess for everybody, including DC, everybody else, what do you guys think about the oral competence? Anything you would do to help with that? And like I oftentimes think that maybe making things a little microstomic is better than oral incompetence. Or any tricks anybody has for that?
I agree with you, Alan. I actually just had the exact type of case today where I had a lady who had a bunch of other reconstructions and she was drooling, and we just made her mouth smaller, did like sort of like a Karapanzik flap, used some local tissue just to make it smaller. I've also done grafts like a palmaris tendon or DFL to try to sling the lymph up to the zygoma and help with that. Sometimes you can't do much. Like I think in this case, like you're right. If you're expecting a Cadillac, you're going to be very disappointed. This type of case, if you can get it to 1999 Corolla, you'll be happy with it. Um, so I think you have to be realistic. A couple of points that I just wanted to bring up. One, whenever I see an ORN that's now involving soft tissue, like an ulcer is developing, there's a hole in the cheek or something like that, I'll always take them to the OR and do a biopsy. Usually there's a bunch of dead bone you can remove to try to clean up the wound. I'll start with that. Sometimes you'll be surprised you'll find cancer, and there are other times it's just horrendous ORN. So I'll start with that, and then I'll really slow play this. I want the patient to have the best result possible, so I'll put them on Pentaclo and see if they can get HBO for a while before we do the big surgery. And in a case like this, I used to put in a lot of condylar head prostheses. I don't think they have any purpose. Most of them don't end up in the middle cranial fossa. They can last for years. It's fine. I think it's just unnecessary. I don't think it improves their function in most patients, especially if they're edentulous like this. Like if her mandible is off, not going to really change her function very much. If you really wanted to do the Cadillac, and I've done this in some select patients with ORN, is you want to get a TMJ prosthesis in there. And if it's not cancer, you have time. They take sometimes 3 to 6 months to manufacture. You can do them with Stryker. I usually work with our oral surgery colleagues who do like 100 of these a year for TMJ disorders. That's something you can do if you really wanted to do the whole Cadillac. But otherwise, I agree with Matt. I don't think I would necessarily stage this. I think you could probably do this whole thing in one stage. But I mean, there's so many different ways to do this, and you probably end up in the same place at the end.
Yeah. Yeah, and I really don't think there's a right or wrong way. And I probably have a weaker constitution than you, PY. I would have just I would have let him swing, do soft tissue, give him that 1991 Corolla. But this is obviously such a challenging case, and I mean, 10,000 different ways to do it, and no matter what you do is challenging. So thanks for presenting it, guys. This one was a really, really cool one. So just in the interest of time, because we got a couple more to go through. Next is AHAM, Dr. Al-Afif from Dalhousie, who's going to give us another case.
Sorry, I stopped sharing because I couldn't see the unmute button. There we go. Can you guys see, Alan? You good?
Yeah, we got it.
So thank you, Alan, for the opportunity to present today. I'm actually presenting on behalf of our fellow, Dr. Crowan. Something came up with him today, but I want to give him full credit for being in this case and for making the PowerPoint. I don't want to take anything away from him, but we have a case of a hemimaxillectomy with orbital exenteration. This is a young lady. She's 46, who presented to our local otolaryngologist with some facial swelling, nasal obstruction, and minor epistaxis on the right side. She's otherwise healthy, but has a history of some obesity. And she has two young children at home. Endoscopy showed a pigmented mass within the nasal cavity. Biopsies came back in keeping with the mucosal melanoma. So she had the usual workup, had a PET scan, showed no distant metastases, but one suspicious lymph node in right level 2A. And based on the extent of the tumor, she was staged at the time as a T4B N1M0. So surgery was discussed with her, and amongst other modalities. And after a tumor board discussion, we decided to give immunotherapy a shot, see if she has any response. And it was felt at the time that the extent of the tumor was too big for anything related to radiation. And so she did have a partial response with immunotherapy, shrunk the tumor down, and we decided at that point to go in with surgery. So this is what her CT scan showed before or after immunotherapy. You can see on the axials to your left a tumor that's kind of involving the maxillary sinus. It is abutting and actually going through the posterior lateral aspect of the maxilla. It is just free of the pterygoid plates, but there's quite a bit of concerning inflammatory change within the lateral pterygoid there, and the masseter and the infratemporal fossa space is a little bit asymmetric. As you can see in the middle on the coronals, she's got some soft tissue thickening abutting the medial and inferior rectus, filling up that space. and very concerning for orbital invasion. And the sagittal on the back there just shows the extent of the tumor posteriorly. So we took her to the OR. Planned two incisions for the surgical approach. One in a subciliary crease with the plan of trying to preserve the orbit if we can see that the fat was uninvolved. As you can tell, probably no surprises there. It was very heavily involved. And so we switched gears to a superior incision just under the brow. And this is the appearance or of the final specimen. We have a portion of the soft palate, as you can see, effectively a hemi-hard palatectomy going to the midline or just shy of the midline, maxillary sinus, and the orbit. And then later, we did go back and revise some infratemporal fossa margins with mucosal melanoma. At least in our center, we don't really have very good handle on frozen section analysis. So we just kind of sampled a large swath of the muscle down to some landmarks. And this is the defect that ensued. As you can see, it involves a hemipalate, orbital exenteration, partial resection of the zygoma, and a large volume of tissue in the postmaxillary space with some of the buccal mucosa as well. And yeah, that's basically yeah. And with regards to the zygoma, I think we took away a little bit of her projection, but some of it was actually preserved. So what we had in our minds, the reconstructive considerations is, it's she still had most of her premaxilla. Do you put bone in there? Do you just do soft tissue, considering the large bulk of soft tissue needed? If you do soft tissue, do you need skin, or can you just use muscle, skin intraorally, muscle to seal the orbit and fill that space just below the skull base? And then obviously we had to consider our pedicle. Did we have enough pedicle length to reach the neck, or should we think about the superficial temporal vessels, or should we be thinking of a vein graft as well? And so with all of those things in mind, we ended up doing a chimeric scapula tip and harvested the whole latissimus dorsi. We went with the left side just due to the orientation. And we had, as often is the case, a single pedicle harvested all the way to the axillary vasculature. The way we orientated it, and this was kind of a bit of a topic of debate. We got lucky when we mobilized the soft tissue off of the tip of the scapula, although the musculature, the serratus, and the fat anteriorly was actually quite nicely mobile off of that. So we could actually reflect that sort of medially and seal off the nasal cavity into the sinus. The other question we had is, and I'm curious to see what everybody here thinks, is there's quite a bit of muscle, as we all know, on the scapula itself when you have parts of the subscapularis and you have parts of the teres. Is that enough to seal the palate? Or, as I will discuss a little bit later, should we bolster it with more muscle along towards the soft palate to hopefully prevent a fistula? Just because the blood supply to that muscle can be a little bit variable. Lastly, the orientation of the bone segment. Do we orientate it vertically or horizontally, thinking in our minds in the future she might be a candidate for some either rehab for her teeth, if possible. We don't really have a provincial program for that during surgery here, but we've thought about it in the future. And lastly, to support an orbital prosthesis potentially. So we ended up using the bulk of the latissimus, starting with the intraoral inset towards the soft palate, midway through the palate, and reflected that latissimus up. As you can see, and the pedicle was tunneled in a plane superficial or lateral to the mandible down to the neck. And this is what we kind of ended up with looking like over there. We used the same muscle to seal the defect, cover the plates, plug the posterior aspect and toward a little bit towards the skull base. And that's basically what we ended up doing when we closed her up. This is what she looked like. Please excuse the buttonhole in the middle of the cheek. That wasn't me. And then we put an NG tube down in the nose, and that's it. We are actually, as far as microvascular goes, we were able to get just enough reach to the facial artery, and we had a very long facial vein, so we felt quite lucky. We didn't need a vein graft. But she did incredibly well, sparing a couple of mucus plugs in her trach. She actually got discharged on day 14 and was tolerating a soft diet. These are her most recent photos, which are about 5 to 6 weeks post-op. You can tell she's healed quite well. Intraorally, that intramuscular bulk has already really started to come down and started to contour to her hard palate. She's heading for a rough course of radiation and additional therapy for this. So this isn't the end of the road for her. But this is all I have really for a discussion. It kind of brings it back to the paper that potentially and arguably started it all by Dr. Gilbert and colleagues from Toronto. So why did we choose the scapula here? We can get a large volume of soft tissue, and we can also get bone to help support an orbital prosthesis and potentially dental rehab, which I'm also curious to see about, the thoughts of the panel. It also helps us with projection in a little bit more of a controlled manner than just soft tissue, which I think would have done okay with. She would have done okay with it. The orientation of the bone, could we have placed it vertically or horizontally to help achieve multiple things in the same way? And then the use of the muscle, as I mentioned earlier, sometimes I feel like the blood supply to the muscle that lives on the scapula is a bit variable. So by harvesting and using the latissimus in its full length to kind of seal both defects, perhaps maybe a little bit more or a little less variable. And then one big consideration here was the pedicle length. We didn't need any vein grafts, as I mentioned, but we were prepared to go to the superficial temporal if we needed to. And like the study, our patient is effectively back to a normal diet. She has good movement of her arms. She has not fistulized and never did during her therapy. But as I mentioned, she's getting some radiation, so we'll see how that lives through it. And that's, I think, all we have. Yep, that's all we have.
Awesome. Thanks, Am. Great, really tough case. One question in general, and then DZ, I'd love to get your thoughts too. Am, did you guys stage the resection and reconstruction, or were you talking about you revised the margins on? For I feel like for mucosal melanoma, our pathologists have a tough time calling frozen sections, and then DZ, maybe you can comment about what you'd think about for this case in terms of bony options, orientation of scapula if you were going to do that, and vessel placement or anything else that you could think of too.
Yeah, thanks, Alex. Sorry, go ahead, Peter.
Oh, no problem. I am. That was a great case. I think I probably would have done the exact same thing there. The idea of like staging something of this sounds great, but by the time you get final pathology on your melanoma, it probably would take a while. Like it'd be great if you could cut it out, wait for the final, like pack it, wait for the final pathology, go back, revise anything, and reconstruct it then. But I think reality is the patient needs to recover quickly and then get to radiation. So you got to do what you can at that time. I think the idea of going back and getting more margins just to be safe is great. I like the reconstruction. I would vertically orient the scapula either side. I would use whichever one the patient has a preference for, or if we can do it simultaneously, in this case, do the left since we're operating the right. We can do two-team approach for it potentially. And then same thing, I would take a huge piece of lat. I like using that to bolster the other muscles that are attached to the scapula. And it looks massive for a long time, but the thing shrinks over months and eventually looks great. So, and same thing, I always prepare for a vein graft just in case, but I'd say most of the time you get surprised and then the vessel's enough length. So I don't have a ton of anything different to add to that one. That one's, very similar to the way I would approach it.
And did you guys tunnel through the parapharyngeal space, or did you go kind of over the mandible? Where did you get the vessels from again? Sorry, I missed that.
Over the mandible.
Over the mandible, yeah.
Yeah, it sat better. Honestly, I was kind of always trained to try and tunnel parapharyngeal, but if I can get away over the mandible, I always find it a little bit easier. And And it's if you get a hematoma there, which I have seen and experienced before, it's a little bit easier to control too. And so that's my preference. Alan and the rest of the panel, is that what you guys go for usually, or yeah?
Yeah, I think I was the same thing. I remember years ago, people who did a lot of these would tell me you need to go parapharyngeal, and I would almost always find that over the mandible seems to work better. And that might be if your defect is more up on the zygoma, your vessels are just naturally going to be sitting over the mandible. Whereas if you're more medial, then you're going to
Hmm.
be in parapharyngeal space. So I think, it depends on the type of defect you have. And I think I just see more where it's going more lateral.
Hmm.
So I think this is a great case. I think it depends on the takeoff of the angular. So a lot of times the angular, if it's short, it's going to shorten the pedicle enough where you'll have to go over the mandible. For this, I would have favored parapharyngeal unless it wouldn't have worked because of how I would have done the lat. I would have put a skin paddle in the lat unless she was really, really big. And then I know you mentioned that she was, she had obesity, but if, that muscle will heal. But if you're trying to get her to radiation for 6 weeks, I just find that a skin paddle can, heal a little bit quicker. The other benefit
Hmm.
of a parapharyngeal tunnel is you could have brought a skin paddle in the mouth and then behind the scapula, the muscle might have filled up there. This is just such a tough defect, right? To go, but the orientation of the lat paddle might have been a little easier parapharyngeal with a skin paddle.
Hmm.
I would have struggled a lot more than you did. I wouldn't have split the lip like the filtral column. Like I've been
Hmm.
taking the Weber Ferguson just like you did and do a lid sparing, orbitectomy or exoneration, but then leaving this part would have, you could do it with this in there. And I don't know. I don't like splitting the lip if I can help it. So I would have done half the work through the mouth and then half the work through the eye, and the face. The other thing is that soft palate, right? I mean, you cut the bone right off the soft palate. So I like skin back there because as that muscle contracts, it's going to pull that soft palate up and probably be okay for a hemi, but it'll
Hmm.
change the orientation of that. I agree with you. I wouldn't have done anything with teeth. I would not put any bone in the infrastructure maxilla for teeth. I mean, she's got a 50% met rate with a T4B melanoma, sinonasal melanoma, and so teeth are kind of the last of the worries, right? It's except separation of the oral nasal cavity, best as you can for the cosmetic projection of the maxilla. A vertically oriented scapula is how I would have put that in just to project the
Hmm.
maxilla. I would have put bigger plates on, like a 1 millimeter longer plate across, but those mini plates probably worked a little easier, and you never have to take them off. I end up taking some of mine off, but
Hmm.
overall, that's a great result for her, and just subtle differences. So
Out of curiosity, would you have done the skin paddle on the lat, or would you have done a parascapular separate skin paddle?
yeah, if I could have got away with a lat, if she wasn't super big, a lat would have worked. And then if it's way too big, I would have just done another flap, an ALT, if that would have been
Hmm.
easier, or picked a different site to do. If the lat, I mean, some of these, if the lat's that thick, there's just no way to get it in there. But if she's got a good site, an ALT could have done the palate like this, and then the scapula like this, and then
Hmm.
that's the other way.
Okay.
Matt, what do you think about in a thick person like that, taking off the skin off the lat and then putting a skin graft right on the muscle? Have you done that before?
Not in intraorally. Intraorally, I think it's probably okay. It just takes a long time. On the neck skin, Steve Chin loves to do that. Put skin
Yeah.
grafts on the ALT and the neck skin, and I just think it gets covered in spit. And I'm not sure the split thickness skin graft takes super well. It's not a bad idea. Maybe you could bolster it somehow to get it to stay up there. But I mean, I think we all real the difference between a skin paddle in there that you get to sew up with. You get great approximation and it heals much quicker. The muscle definitely heals, and I've done a billion scapulas that way where you just let the muscle heal in, and it does fine, and it just takes a long time. But never skin grafted intraorally on a maxilla defect. I just don't know.
All awesome points. I mean, great case, Aham. There's a lot to unpack here. I could probably talk about it for another 20 minutes, 30 minutes, hour, but yeah, this is really interesting and really nice outcome for her for a really tough disease. Um, okay, so last case, and we're right on time, and so I'm proud of all of us. Great job, guys. Last case is from Toronto. So I don't want to misprint. Is it Noemi?
Noemi, yes.
Noemi. Okay, perfect.
Yes. So, hi, I'm Noemi Villemot-Ponquet. I'm the clinical fellow at Mount Sinai Hospital in Toronto, and I'm presenting our case on behalf of Dr. Joel Davies, who's connected to the call. So I'm going to try to keep this quick and just present the case. So our patient is a 44-year-old female who was referred for a right mandibular slash submandibular lesion. No significant medical history. She's a non-smoker, doesn't drink alcohol. She basically had a 6-month history of very intense right mandibular pain, dental pain, and V3 numbness. The pain eventually progressed and she presented to the emergency department with severe pain and trismus. She was referred to an outside ENT in the community and she had a biopsy which showed an adenocarcinoma, which was initially thought to be a metastatic disease. So here's her CT scan. She had like this mandibular lesion associated with the right anterior dentition, cortical remodeling and destruction. That's really evident on the images here. She also had an MRI which showed intense infiltrative bone marrow involvement from the symphysis to the parasymphyseal mandible from T36 to 44. So pretty significant and distant involvement. Because it was thought to be metastatic, she had a PET scan which showed the diffuse hypermetabolic mandibular lesion that was crossing the midline. But she also had a MET in her right mandible and some small bilateral hypermetabolic lymph nodes in the neck. So her case was discussed at the tumor board and at the reconstructive rounds. We eventually decided to do a resection of both oral cavity, segmental mandibulectomy, bilateral necks, tracheostomy with a right clavicular resection, and a left fibrillar free flap reconstruction involving 4 segments. The main point of discussion for the reconstructive rounds was what to do with the left condyle, particularly. The discussion was between either removing the condyle completely versus leaving a small piece of the condyle and using mini plates to fix it on the fibular free flap. There was no discussion of putting a prosthesis because the patient was supposed to have adjuvant radiation therapy. So this is just some images of the VSP planning. So you can see on the right side, you have the condyle in the neck that's preserved with a pretty high cut, removing the coronoid process as well. On the left side, you see the condylar head, but no neck, so a very, very short segment left inside too. And you see how the reconstruction is planned with the 4 segments. And you can notice on the image on the bottom that she's a bit retrognatic because of the limitation in the bone and the vessel length. So these are just some images from the resection. So this is the mandibular resection you see here. The left fibula, the template with the 4 segments. And here how the reconstructed mandible looked. So on the frontal side, you can see that the pedicle with the blue arrow is very, very limited. You have the right side in the upper image, and on the left side, you see that the plate is a little bit shorter to leave room for the mini plates. And this is how it looked in her mandible, like once everything was put in place. So the pathology returned as an adenoid cystic carcinoma with a 30% solid component that was poorly differentiated. All margins were negative, although a bit close, with the closest at 1 millimeter. There was 1 node positive, and her final stage was PT4N1M1. At the post-op tumor board discussion, the decision was made to not give adjuvant radiation therapy. There was a few reasons. First, the patient had some wound complication. She already had some intense trismus, and there was suspicion of further bone mets. So the group decided to not recommend adjuvant radiation. At her 3-month follow-up, she presented with even more severe trismus, now limiting speech and oral intake. She had a repeat CT scan, which showed important mandibular misalignment, especially at the left side. You had distraction and fracture of her left reconstruction and anterior dislocation of the right condyle, but no evidence of local recurrent or residual disease. And this is actually her 3-month, actually her latest CT scan showing the post-op changes. So on the upper image, you have the right side that's completely dislocated anteriorly. And you see the bottom image is the left side with the pretty drastic fracture and distraction of the condylar head compared to her reconstruction. So we mainly wanted to discuss 2 points tonight. So the first one was obviously the initial management of the condyles during the first mandibular reconstruction. Of course, we thought that she would have radiation therapy, so the options were a bit more limited at the time. And we also wanted to discuss further management of the displacement, the dislocation, and the fracture of her current mandible with the group. Thank you.
Awesome. Thanks so much. Really, really tough case. Joel, I guess first question for you, kind of, can you walk us through how you were thinking about the condyle, like, and
I think you froze, Alan.
He did freeze. It's just him, I think.
Yeah. Sorry, you froze there, Alan. But I think
sorry.
your question was about management of the condyle.
Yeah.
Yeah. So, normally I would think about doing a neocondyle. And actually in the past, so all this is done in-house, all our VSP is done in-house. In the past, we've actually created cutting guides that actually kind of create a new condyle with cutting slots that create a new condyle, and then usually we'll drill little holes and then suture it up to the articular disc, which is really nice. But in this case, we didn't have enough bone. There just wasn't enough bone left given it was quite a large four-segment fibula. And so when we discussed throughout our case rounds, there was kind of differing opinions on do we remove the remnant condyle that's there and kind of plate it to the fibula ex vivo versus leave it in situ and mini plate and use mini plates. But my thought was, if we remove it ex vivo and plate it to the fibula, well, now it's totally devascularized. And I was worried if she gets radiation, it's going to start to necrose. And as Noemi had mentioned, we did think about a TMJ prosthetic, but again, it was kind of the same thing. We were worried about the post-op radiation. In hindsight, obviously, we could have used it, and that's the plan now. Is we're going to go back and do a TMJ prosthetic, but it was a challenging case. And the other thing I think I didn't really, well, I guess I anticipated it, but I didn't know how to manage it. We basically stripped all of her muscles of mastication off the mandible during the resection, and so how do you account for that? And we tried to suture back the masseter, onto the fibula, but it's really tough. All those muscles get stripped. Her digastrics, everything gets stripped away from the mandible, and so all of the normal forces that you would have post-op are gone. So anyways, tough case, but I'm interested to hear what other people think.
I think this is a tough case. I think that the expectation setting, right, is the first thing. Like you cut every muscle off, TMJ prosthetic or not, you go put a prosthetic in there and you're going to be stuck with the same trismus, right? It's not like that's going to somehow improve. I mean, probably the goal of not drooling, right? Oral competence and, maybe trach dependence for life. I'm sure she's still trach dependent. With maybe the mouth there, and then just being able to not talk, not move your jaw at all, but talk with your tongue on the inside. Even the tongue you had to cut off, so that's going to be a long time healing. So yeah, I don't know that you could have ever got a mobile jaw. I mean, obviously the fracture that you have are not ideal, but in some ways, anything else you could have done and wouldn't have probably changed that. Yeah, I guess the only thing, if I would have made sure that little segment on the right that had like a little strip of whatever there, I might have made sure I cut all the muscle off of that because that was just going to give you more trismus. So anything you can do to like that little thing right there, making sure there's no medial pterygoid muscle on that because all that's going to do is sock right back up there. So I guess the goal would be to disconnect all the muscles and just hope that they, as things scar in, it's not, it's because trismus is going to happen no matter what. So I would have tried to do anything I could to get as much open as possible.
Yeah, DZ.
It's a really good point about the medial pterygoid, and we didn't do that actually. That's a really good point.
Yeah, I was thinking the exact same thing Matt just said. Try to just get rid of all the muscles. You already got rid of the coronoids, so you get rid of the temporalis attachments, but try to clear all that muscle out of there. That's a disaster. If you end up clearing it all out and you end up with an open mouth deformity, you can fix that by slinging the mandible up, but the trismus is, something you're not going to be able to fix. And you may 100% of the time end up with that in this case anyway. It's tough. Um, yeah,
Yeah.
I think the one question I was going to ask actually the panel, I noticed on the picture, this doesn't really matter for this case, but on the picture, um, at the osteotomy sites, you have kind of like small gaps between the bone. And something I was just discussing with my fellow was like, if, I don't know if there's a known, like, what's an acceptable gap? What do you guys think? Is there like, you guys measure 1 millimeter, 2 millimeter? It's got to be 100% tight. What are you guys' thoughts on that?
I would have liked a tighter fit. This is hard to do. Those are plastic cutting guides. Probably doesn't matter. I don't use cutting guides, so it's hard to know. I know there's like kind of three types, right? There's plastic, you can get a slot, and then you can get a wall. And I think they're all different in everybody's hands. So whatever you're used to using, but there's going to be there's always a little bit of give in everything that you're doing there. And so I think that's hard to get four segments perfect like that. So when I look at that, I'm like, okay, four segments, that's tough to do. That's pretty good. Would I have wanted it tighter and would I have been critical of myself and my fellows if we were doing it? Yes, but at the same time, like that's pretty good to get it in there.
Yeah, that's so many segments, and you're in two different planes there, right? So you're in one plane on the left side of the back, and then a separate plane, and then four segments, even with VSP. And kind of to Matt's point, and just for the fellows, like something I know, when you're using those cutting guides, you think it's foolproof. It's not. You can cut into the guide all the time. You're way off. There's also a thickness to the guiding slots and a thickness to your saw blade. So you have to take those into an account and also into account when you plan. Ask for the right saw blade, know how big your slot is. Um, and I think Dr. Mannion, I saw your virtual hand up from I don't know if you're still
Yeah.
there.
Yep. Thanks, Alan. I just have one more comment on the muscles, and
Yeah.
PY has heard me make this point before. I think a big part of this too is that we're taking all your vertical muscles off, but we're most of the time, and I do the same thing. I've had this same problem leaving the lateral pterygoid on because we're trying to maintain blood supply to that small remnant that's left and leave some functional muscle. And I think that's what's pulling both of those condyles forward, causing the fracture on the left, is that you just have unopposed function of your lateral pterygoid, and your condyle's not tightly up in the joint anymore after that resection, especially on the left side. I don't know that there's a good solution to that. I mean, you can release your lateral pterygoids too, but then you have nothing left holding things together in there. And there's no easy answer to this, but I do think that's part of kind of the final position of both those sides. That's probably what drove it, was just the fact that the lateral pterygoid was still there and still functioning.
For sure. Um, Joel, in terms of one question is because how much bone was this actually? I didn't see like the measurements. Because I don't know, I don't know about anyone else's experience, but pushing like the length of your fibula in general. Um, but I don't think I've ever done a four segment fibula or needed that much bone. But like, how tall was she, and was that a factor? Like, if she didn't have enough bone in the fibula, what would you have thought about? Because this is like pushing, and maybe you got lucky. Maybe she's like 6'5" in the WNBA or something, and you just got a lot of bone to work with. But it looks like you had a lot of bone in this case. What happens if she's like 4'2" and doesn't have as much in the fibula?
Yeah, so I think going back to your question about how much fibula, I don't remember the exact amount, but it was something like 12, 13 centimeters or something like that. It was almost her entire. I mean, we left 6 centimeters, obviously distally, 6 centimeters approximately, but everything else we used. Um, she's not actually that tall. She's probably like 5'3", 5'4", or something like that.
Oh, wow.
Um, and so, yeah, I mean, if we didn't have enough, I mean, given this case, I probably would have just let her swing on that one side. Um, she already had a met in her clavicle, and so we kind of knew this was mostly palliative.
Yeah.
So I think trying to do like a double fibula or something like that is probably too much for in this case. But so yeah, I would probably just let her swing on that one side. And in the end, if I let her swing, at least she wouldn't fracture.
Yeah, I mean, like this is a really, really tough case. In general, I guess just a general question to the group, and more so for um, kind of just a general consideration. When you guys are doing these anterior segmental mandibulectomies and then anterior composites in general, I think are just really hard on patients. What do you guys think about in terms of projection? Do you try and go back to native projection? Do you try to deproject? How much do you try to deproject? Do you have any general guiding tenets or rules that you follow?
I would deep project. I use a 2.5 millimeter plate, so I know that I can deep project by 2.5 millimeters, and by that already, it's the same projection. Especially people with bigger chins, right? The areas you got to be careful of are the sides because that's where the plate exposes. Right? For some reason, the plate always exposes in the same spot, and so having tissue around like where your corner is, you don't want that too proud there. And so yeah, deproject the mandible. Um, there's some dental considerations if for patients who think they could get implants, but that's pretty few and far between. So, as a rule, I guess rule of thumb or common thing, I would deproject, make sure I get the teeth as good as I can, or get the occlusal surface as good as I can, and the mandible still in projection. So.
Do you think the same thing, DZ? Do you tend to try and deproject at least a little bit there?
Yeah, in most cases, for sure. I try to line up the fibula where the teeth would be if they were to get implants. Um, and yeah, just like Matt said, if you have somebody with a strong chin, I'll deproject it. And same sort of idea. I like to use slightly thicker plate, 2.5 millimeter or two, and so that gives you a little bit more. And I was thinking the exact same thing. You get those spots where it's going to expose. I learned that early in my career. It's always on the side, especially in a thin patient. So in those, certainly deep projecting helps, especially if you think your resection is going to involve a bunch of the vestibule and you're going to lose some of the muscle in the chin. Then definitely think about that.
Yeah. Yeah. And that I always try to deproject as well. And I try to avoid tracheostomies in a lot of patients, even when I do segment mandibulectomies, bony work. But those anterior composites are the ones that are hard to avoid, especially if you're taking a lot of it and kind of releasing all of this suprahyoid musculature, just because their tongue tends to go back to, if you're taking some of the ventral tongue, the floor of mouth, and kind of fall back. But all right, we're a couple minutes early, so I think this is good timing. Thanks everybody so much. Big shout out to DZ, Dr. Spector, for joining as our expert discussants. Dr. Manu, thank you for the comments. Everything was super helpful. Dr. Davies, Dr. Yalamanchi, Dr. Alafif, all the fellows who joined us. Thanks for presenting and taking time to make these. I know it's a lot of work, but I think there's a lot of really good learning points here and a lot of good discussion. So thanks, everybody, and have a good night.
Thank you,
Thanks so
Alan.
much, Alan.
Thanks,
Appreciate it.
Alan.
All
Great
right, see you
job.
guys.